movement disorders, man. So today I'd like to go over just a brief overview of some of the movement disorders that we commonly see. So basically, movement disorders is a subspecialty of neurology that includes both hyperkinetic and hypokinetic abnormalities. Generally, it's limited to the disease of the basal ganglia, and diagnosis is it's very objective, it's very clinical. By the way, I have a disclaimer that these slides are borrowed from a Movement Disorder Society, which provides us with these slides for educational purposes only. So some of the examples of movement disorders, we can broadly divide them into hypokinetic and hyperkinetic. Hypokinetic, most common movement disorder is Parkinsonism, which is further divided into various types of Parkinsonism. Dystonia can sometimes also be considered in the hypokinetic disorder, but mostly we label it under hyperkinetic disorder, which is other hyperkinetic disorders are tremor, chorea, tics, and myoclonus. Give me 1 second here. Is that good, Dr. Rao?
Yes, thank you. Please proceed.
Okay. So firstly, we'll go over just briefly over Parkinson's disease. So we'll try to cover as much as possible in about 45 minutes and then leave the rest for question and answers. So Parkinson's disease was first identified by James Parkinson, who saw in London, he saw people with Parkinson's, these typical features on the streets of London. He described the features, and later on, when more cases were seen, it was finally labeled as Parkinson's disease by subsequent neurologists. The diagnosis of Parkinson's is basically based on key clinical features, which include bradykinesia, which is one of the key features of Parkinson's. The other include resting tremor and rigidity, and these are basically, 2 out of these are required for the diagnosis of typical Parkinson's disease. Other features include supporting features, which are masked facies, hypovolemia, swallowing difficulty, micrographia, shuffling gait, difficulty with walking, such as akinesia of gait, which is difficulty with starting the gait, and freezing of gait while they're walking. So these are all supporting features and are helpful when you see those features. But earlier on, we don't see all these typical features. Usually, Parkinson's is a slowly progressive condition, so if we see patients who have symptoms that come on suddenly, we think of other reasons than not typical Parkinson's. So idiopathic Parkinson's disease makes up the majority of the cases of Parkinsonism. Other varieties include neuroleptic induced Parkinsonism or multisystem atrophy, which include newer classifications: multisystem atrophy, Parkinson, MSAP, MSAC, which is more Parkinsonian features versus more cerebellar features, which is the olivopontocerebellar degeneration. And then if you see more autonomic features, then you have the Side-Drager syndrome. Other atypical Parkinsonism syndromes include the progressive supranuclear palsy, corticobasal degeneration, which is not listed here, vascular Parkinson's. Vascular is typically more lower limb involvement, and then Parkinsonism secondary to MPTP toxin, carbon monoxide poisoning, manganese exposure, recurrent head injury, and post-encephalitic, which is not seen anymore. The basic main abnormality is loss of dopamine. And by the time patients have symptoms, they've lost about 70% of dopamine in the brain, which correlates with about 50% of dopaminergic neuron loss. People with less than 50% dopamine loss are asymptomatic, and by the time people die with Parkinson's, they have lost more than 90% of dopamine. So this is basically the structure of basal ganglia, which includes the caudate, putamen, globus pallidus interna, externa, subthalamic nucleus, and other nuclei that are also involved, but typically these are the big structures that we think of when we think of Parkinson's. And you can see in this pathological slide, the top slide has adequate staining in the substantia nigra, and then the lower section shows decreased staining. And you can see the Lewy body on the right slide as well. So the basic criteria, at least 2 of the 3, resting tremor, bradykinesia, and rigidity. Typical, most important of these 3 would be bradykinesia. Absence of any secondary cause, such as drugs, which include neuroleptics, antipsychotics. A common GI medicine includes metoclopramide, which we see over here a lot, not a lot, but quite a bit. And the definitive diagnosis can only be made by autopsy. Clues suggesting atypical Parkinson's disease include early onset of progressive dementia. So if we think about early onset of dementia, we think about Lewy body dementia, which most of the time has associated Parkinsonian features. If someone has rapidly progressive Parkinsonism, again, that would be unlikely for or atypical for typical Parkinson's disease. Supranuclear Gale's palsy, more suggestive of PSP. Upper motor neuron signs, we think about stroke or any other reason that would cause that. Cerebellar signs such as spinocerebellar ataxia or olivopontocerebellar degeneration would present like that. Urinary incontinence, early symptomatic postural hypotension, more suggestive of multisystem atrophy. As far as treatment of Parkinson's is concerned, as of yet there is no clear-cut strategy, treatment that is available to prevent or prophylactic Parkinson's or delay the progression of Parkinson's. However, monoamine oxidase inhibitors have been used as has been studied and shown that they may delay the progression of Parkinson's in early on cases. This was seen in the Tempo study and Adagio study. But otherwise, there is no definitive preventative therapy available. Symptomatic therapy includes both pharmacological and surgical. Parkinson's also includes non-motor symptoms, so we have to look at those as well. And then experimental therapy is available as well. So the big classes that are used in dopaminergic in Parkinson's disease, typical Parkinson's disease, are dopaminergic agents such as levodopa, dopamine agonist, catecholamine transferase inhibitors, and MAO-B inhibitors. MAO-A is also available, but typically MAO-B are safer and more commonly used. Anticholinergics and amantadine. Now, as far as going a little bit more about the dopaminergic agents or symptomatic treatment, we tend to delay the use of dopaminergic agents as much as possible. Early on, try to use more MAO-B inhibitors, something like we have rasagiline here, selagiline. Sometimes we use amantadine. So we try to delay the use of more potent dopaminergic agents, the most potent being levodopa. They actually have the best symptom relief. However, the risk is the motor complications that Parkinson's disease patients later on develop with the dopaminergic agents, such as dyskinesia and fluctuation. So that's why we try to delay their use as much as possible. As far as surgical treatment is concerned, people who respond to dopamine are the ones who are going to respond to surgical therapy. And basically, we tell patients who are candidates for surgery is that whatever benefit you get from dopamine, surgery will maintain that benefit most of the time or throughout the day. So that is the only benefit of surgery. Surgery will not bring back whatever has been lost or slow down the progression of disease. It only is symptomatic treatment again. So best patients will be with severe dyskinesia requiring a lot of dopaminergic medicines, fluctuations with best medical management or medications. They should have symmetric symptoms, which are typically seen in typical Parkinson's disease. They should be levodopa responsive, because whatever responsiveness they have with levodopa, that is the benefit they will get from surgery as well. And we expect to see more than 30% improvement in the UPDRS scale, which is the UK Parkinson's disease rating scale, before surgery is considered for those patients. We ideally would like to see that. And absence of significant dementia, bulbar symptoms, and autonomic symptoms, which are suggestive of atypical Parkinson's. So surgical treatment has previously pallidotomy has been done, these are very rare procedures now. Pallidotomy is still considered where finances are concerned, or availability of safer procedures such as deep brain stimulation is a limitation. But most commonly used surgical approach these days is deep brain stimulation of the globus pallidus interna or subthalamic nucleus. Until about a year or so ago, everybody was gung-ho about using subthalamic nucleus as a nucleus of choice. However, recent studies have come out that have suggested that there is actually no significant difference between the use of either globus pallidus interna or subthalamic nucleus. And then there are experimental therapies or gene therapies that are being used. So far, these studies have shown mixed results. Individual patients have had benefit with these studies, but overall, there hasn't been significant benefit seen with gene therapy at this point. But current studies are ongoing. Next very common movement disorder is essential tremor. These are basically involuntary, rhythmic, oscillatory movements of one or more than one parts of the body, produced by alternating or synchronous antagonist muscles. Basically, essential tremor is classified into resting tremor, which is most typically seen with Parkinson's, however, sometimes in essential tremor as well. But otherwise, action tremor, which is can be postural or re-emergent tremor. Re-emergent tremor we see typically in Parkinson's disease, in which case people, when they're asked to hold their hands outstretched, typically we see essential tremor or action tremor in that position. But in Parkinson's disease patients, the resting tremor re-emerges with the same frequency as you see at resting position. Kinetic tremor, that includes this initial tremor, like intentional tremor, and terminal or endpoint tremor. Then there is task-specific tremor. These people develop tremor with performing specific tasks such as writing or using the hand on the computer with specific action only, and asymmetric tremor. Age of onset for essential tremor, it's kind of a bimodal. Early on in teens there's a peak, and then later on people in their 50s to 60s develop essential tremor. Most common type of essential tremor is typically in the hands, followed by head and voice, legs, jaw, face, trunk, tongue. So a variety of essential tremor. And people usually start in the hand, and the tremor spreads to the head or voice and jaw, stuff like that. But typically, if you start seeing chin tremor, that is highly suggestive of Parkinsonian tremor. Jaw tremor is more suggestive of essential tremor. So core criteria for identifying essential tremor includes bilateral action tremor of the hands and forearm, but not resting tremor, although rarely that is seen as well. Absence of other neurological signs, with the exception of cogwheel phenomena. People who have essential tremor for years and years or decades, they sometimes develop subtle Parkinsonian features. However, that is more related to the presence of long-term essential tremor. May have isolated head tremor with no abnormal posturing. Abnormal posturing suggestive more of dystonic tremor. Secondary criteria for essential tremor includes long-term duration, at least 3 years or longer. Family history is helpful, and beneficial response to alcohol. The red flags for that are not essential tremor include unilateral tremor, focal tremor, leg tremor, which is typically seen in Parkinson's disease, gait disturbance, although long-term essential tremor has been associated with gait instability, rigidity, bradykinesia, and resting tremor. Again, tremor that comes on suddenly, we think about psychogenic or drug-induced or something like that. Occurrent drug treatment may cause or exacerbate tremor. Isolated head tremor with abnormal posturing, again, that is more suggestive of dystonic tremor. So a little comparison of tremor that comes with PD versus essential tremor. Usually you don't see a family history of Parkinson's, whereas in essential tremor, more than 50% have positive family history. And we think that that's what's called familial essential tremor, that there may be a gene involved which has not been identified as of yet. There is improvement with alcohol with essential tremor. Usually people have it for years and years before they even come in for treatment. Age of onset can vary, but in Parkinson's it's usually late 50s to 60s. Tremor type in Parkinson's is more postural and resting, whereas in essential tremor is more postural and kinetic. Medical treatment of essential tremor, most commonly used agents include propranolol and myoclonus or primidone. We prefer using primidone more and propranolol as a second agent. However, both have good benefit, more than 50 to 60% tremor control. Gabapentin, benzodiazepine, zonisamide. Zonisamide comes before gabapentin, and then Topomax as well, topiramate. Typically, if it's significant essential tremor and people want good control, we have to use more than one agent, probably lower dose, to avoid the side effects associated with these agents. And then, last but not least, DBS of the ventro-intermedial thalamus, which gives more than 90% tremor control, by the way. Dystonia. Dystonia is a movement disorder which is characterized by sustained muscle contraction, which frequently causes twisting or repetitive movements and abnormal, painful postures or positions. There is a bimodal age of onset, with the latter being at 27, age 27. It varies, but typically between 26 to 28 is the before that age. Usually we see describe it with early onset, and then more than 26 to 28 years would be late onset dystonia. So classification, basically primary dystonia or dystonia is the only sign in these patients. There is no other secondary causes or anything that can be identified. Usually there is a childhood onset, which is associated with DYT mutation, and then secondary dystonia, which is associated with any hereditary or neurological disorders, and can be associated with cerebral injury, neuroleptics. Otherwise, it can be seen in Parkinsonism, such as multisystem atrophy. Actually, that if you see dystonia with Parkinsonian features, you think about atypical Parkinson's, and then psychogenic causes. As far as distribution of dystonia, we usually divide it into focal, where it's only a single body region is involved, such as writer's cramp, or segmental, where two or more contiguous body regions involved, such as blepharospasm, and then cervical dystonia, something like that. Multifocal, where more than one body region is involved. Generalized, where widespread involvement, or hemidystonia, which is unilateral, that is commonly seen post-stroke. So focal dystonias include blepharospasm, oromandibular dystonia, Mage or Marsh syndrome, cervical dystonia, laryngeal dystonia, which is spasmodic dysphonia, two varieties of that, adductor or adductor types, more common being adductor type. And then limb dystonia, which is task-specific dystonia such as writer's cramp or musician's cramp. This is a picture of cervical dystonia. The gentleman here has retrocollis, where the head is pulled back and maybe turned towards the left a little bit. The lady here has a lateral turn, and so that would be laterocollis. As far as treatment of dystonia, the ABCs of dystonia include artane or trihexyphenidyl. Most studied drug benefit is mixed, baclofen, clonazepam, most effective agent being botulinum toxin. Other useful drugs include Valium, tetrabenazine, levodopa is listed there. However, that's mostly used in DYP-associated or young onset people with kids with dystonia, because DYP5, I believe, is dopa-responsive dystonia or Segawa disease. And so kids are given the benefit of doubt by giving them a trial of levodopa high dose. Amantadine, dopamine agonists, and anti-epileptics are sometimes helpful as well. As far as botulinum toxin, which is the most common agent used here for dystonia control, most effective, has 7 varieties. The type A and type B. Type A has 7 varieties. The ones that are used are basically, as far as A and B are commonly used, however, A is more common than B. And basically the mechanism of action of botulinum toxin includes inhibits the acetylcholine release by acting on specific proteins. Now these proteins actually attach the synaptic vesicle to the membrane, plasma membrane, and these botulinum toxin actually cleaves those proteins, which in type A includes SNAP25, type B, synaptobrevin, type C, syntaxin, as you can see in the picture on your right. And as far as surgical treatment of dystonia, DBS of the GPI nucleus or globus pallidus interna has been approved as a compassionate basis, because this is a very debilitating condition, and until botulinum toxin was out, was very hard to control. Tic disorders. This is a spectrum of disorders ranging from simple transient tics to Tourette syndrome. It includes motor and vocal tics, which can be simple or complex, and the symptoms tend to wax and wane, often change location over time, and often resolve over time as well. So they're basically defined as brief, sudden brief, often stereotyped movements or localization, occurs on otherwise normal neurological background, usually suppressible. So we ask these kids or young adults if they can suppress them, and most of the time they are able to. And the other phenomenon that is commonly used with Tics disorder is release phenomena, which is once they're able to suppress it, like they're in school, it's embarrassing, or in front of during a gathering, they will beg leave, they'll go out and release all that inner anxiety or restlessness that they've been able to suppress. Simple tics include eye blinking, head jerking, shoulder shrugs. Complex include clapping, kicking, touching, echopraxia. Simple vocal tics include throat clearing, sniffing, barking noise, whistling. Complex vocal includes meaningless words or phrases, echolalia, or just repetition of what others are saying, palilalia, or repeating whatever they say themselves, they just keep repeating that, or coprolalia, which is repetition of foul language. Tourette syndrome, and by the way, tic disorders usually is seen in young kids nearing their menarche and puberty, and usually resolves by the time they reach their late teens, 18, 19-year-old. Rarely it will continue after that. Tourette syndrome usually onset around age 21, characterized by fluctuating multiple motor and vocal tics. And typically, behavioral disorders that are associated with Tourette syndrome includes ADHD or attention deficit hyperactive disorder and obsessive compulsive disorder. There is a strong belief that there is a genetic, it is a genetic disorder, likely autosomal dominant. However, the responsible gene has not been localized yet. There is an association that has been noted and based on autoimmune mechanism, which is associated with group A streptococcus infection in kids. However, this is still a lot of people dispute this concept, and so I have seen a couple of kids with previous history of streptococcal infection who developed tics. Usually, with those kind of patients, those symptoms resolve within a few months. And treatment of tic disorder usually is dependent on the severity of the symptoms, and if it doesn't bother the patient, it doesn't bother the physician. However, these associated psychiatric and behavioral abnormalities may be more problematic and may require some control. So treatment includes clonidine that reduces central noradrenergic activity, dopamine blocking agents such as atypical neuroleptics, Risperdal, Haldol, and dopamine depleting agents such as tetrabenazine and rezapine. Rezapine is rarely used, mostly tetrabenazine. Usually, like I said, begins in childhood, peak in early adolescence, and decreases in severity in teenage and adult years, and associated psych disorders. Myoclonus. This is a sudden, brief, shock-like, involuntary movement caused by muscular contractions. It can be positive myoclonus, as you can see in patients who've had anoxic brain injury, where you see myoclonus in different parts of the body, or negative myoclonus, which is seen, a good example is SRX, seen in liver failure. Myoclonus is classified as can be physiologic, essential, epileptic, and secondary. So physiologic examples would be hypnic jerks. As you're falling asleep, you see some myoclonic activity or jerks. That would be physiologic. Or hiccups would be physiologic myoclonus. Essential myoclonus usually can be seen in families in teenage years, starts in teenage years, and continues for the rest of the life. Not associated with any significant neurological abnormality. Epileptic myoclonus seen in different mitochondrial epilepsies or other neurodegenerative condition. And secondary myoclonus could be secondary to medications or brain insults like anoxic brain injury or strokes. As far as distribution, myoclonus can be focal, limited to one area of the body, multifocals, segmental, or generalized. Treatment is basically treat the underlying condition. Mostly metabolic conditions will call myoclonus. So Depakote or valproic acid, levetiracetam, clonazepam, piracetam, and benzodiazepines, phenobarbital are all used for myoclonus. Huntington's disease. This is basically a very devastating condition which involves the chromosome 4, which carries the Huntington gene, and then on the Huntington gene there is a abnormal protein that affects the CAG repeat. And basically, if we have patients who have less than 35 permutations, they are asymptomatic. Between 36 to 39 usually or mostly are asymptomatic. However, more than 40 are almost always symptomatic. And if you're above 60, the higher the number, the earlier the onset of symptoms of Huntington's disease. And other important thing is that if the symptoms, if the gene is transferred from the paternal side, there is earlier onset and more severe symptoms have been reported. So a complex mechanism has been explained as far as the Huntington's disease pathogenesis is concerned, which includes CAG repeat expansion that leads to misfolded protein stress, there's interaction with other proteins and protein aggregation, basically leading to mitochondrial dysfunction or some kind of inflammatory process, and in the end leading to oxidative stress and apoptosis. Three main categories of symptoms associated with Huntington's disease include the big category is motor. Typically, patients who have early signs of Huntington's disease will sometimes have abnormal fidgetiness. They tend to move with restlessness or unusual, very mild symptoms, which later on progress to chorea, mostly distal chorea involving the hands, motor impersistence, unable to maintain posture, unable to maintain, such as milkmaid's gait has been described with chorea, unable to maintain tongue protrusion, and even dystonia, myoclonus, Parkinsonism, and gait disorders. As far as psychiatric symptoms usually precede the onset of motor symptoms, and they include severe depression, paranoid behavior, personality disorders, obsessive compulsive psychosis, which can be seen later on. And then later on in the condition, patients develop dementia or executive dysfunction as well. As far as treatment of Huntington's disease, chorea is the most bothersome or troublesome motor complication, and usually treated with medicines like amantadine, and if that fails, then tetrabenazine is very effective. It's the only drug approved here for chorea control. And then mood disorders are more commonly seen, can be treated with any of the antidepressants such as the tricyclics or selective serotonin reuptake inhibitors, and sometimes neuroleptics are also required. And then psychosis is treated with the atypical or typical neuroleptics. That's it. Any questions?
You are all unmuted for Q&A session.
Hello.